Morning students, I have already conveyed you the respiratory system first lecture. This is the second lecture, treatment of the bronchial asthma and COPD. This is the chronic inflammatory diseases of the airways, and it is because of the what is this pathophysiology and different armamentarium means drugs at different stages of life, like childhood, adolescence, adult, how you have to take the care of this, what is the COPD definition and the difference between COPD and asthma. And then you have to have the different formulations like oral, parenteral and inhalational, and you have to deeply go yourself about the particle size at the time of the inhalational and inhalational corticosteroids, what is their role, and the different formulations of inhalational, how you PDMI, and then PMDI means it is the meter dose inhalation. Then different solvents like HFA, and then what is the different dosage, how you have to give, what is the delivery system. Then you have to tell about the beta 2 agonists, bronchodilators, and methylxanthine, then steroids, then different beta 2 agonists. So this is junk of all lecture will be over here, and this you have to really go through, because respiratory system is to be defined and you have to be an expert of therapeutics. And as you know, this is a hilly area. These kinds of the diseases are prevalent over here, and you have to take care of these patients. And now, definition of the bronchial asthma is chronic inflammatory disease of the airways with the participation of the various cells and cell elements, particularly mastocytes, eosinophils, T lymphocytes, macrophages, neutrophils, and epithelial cells. This inflammation causes in susceptible individuals recurrent episodes or attacks of wheezing, cough, dyspnea, chest operations, mainly during night and in the morning. These are the two, during the night and in the morning there is a wheeziness. Concomitantly, there is a diffuse but variable obstruction of the airways, which is often reversible either spontaneously or after treatment. The inflammation is responsible also for enhancing bronchial hyperactivity in various stimuli. Now you see here, you can see the normal bronchiole. It is already in the dilated form on the left side. On the right side, there is a vasoconstriction. It is because of the antigens and in the airways which take place in the epithelium, and T helper cell, interleukin 4, interleukin 13. These are the inflammatory chemokines, and these all are inflammable because there is a constriction. With the result, there is a wheeziness, there is a constriction, and there is a inflammation like that. Now, pathogenesis of the bronchial asthma. What is the pathogen? Is the eosinophil inflammation is there, and there is a plasma, there is a leakage in that, and there is a bronchoconstriction, edema of the mucous membrane, there is a plasma leakage, vasodilation, hypersecretion of the mucus, their activation of the sensoric nerve endings, cough cholinergic reflexes, because there are cough cholinergic systems are activated and they produce the reflexes mechanism, and the remodeling of lung parenchyma, fibrosis there, smooth muscle hypertrophy, more vessels and cells are involved. Symptomatology is based on the pathogenesis. Now, definition of COPD. COPD is disease characterized by limitation of air flow through airways, which is not completely reversible. Though limitation of air flow has usually progressive character and is associated with inflammatory reaction of lungs to various particulates or gases. So COPD is not really reversible, but asthma is reversible. So we can see pathogens of COPD is because of the cigarette smoking. Smoking is the most prevalent in this part of the country, and people in the cold areas, they go for cigarette smoking and they go for hookah, and because of there is the neutrophils and macrophages, that is, I would say this is oxidative, and this is this free radical mechanism is there, and decrease in anti-proteases, alpha-1 antitrypsin and secretory leukoprotease inhibitors, and increased mucus secretion is there also, plasma leakage is there also, isoprostanes like PGs, bronchoconstriction is there, and neutrophils and tumor necrotic factor, interleukin 8, and these all cascades of reactions take place in the COPD. Now, pathologic changes and the inflammatory mediators in asthma and COPD. What is the difference between asthma and COPD? You are supposed to know. Asthma is allergies and COPD is due to the smoking or the irritants. So both have airways inflammation, macrophages, CD3 and CD45, lymphocytes, interleukin 4, and LT, leukotriene B4, mucus secretion is there. So with this, the asthma produce the parenchymatous not involved here. BSM enlarged in large airways, CD4 and T helper cells, eosinophils, mast cells, interleukin 4, interleukin 5, interleukin 13, because it's allergen, so asthma. But here we have BSM enlarged more than asthma, and in small airways, CD4 is there, neutrophils, LT4, B4, TNF alpha, and interleukin 8. And we can have this reversible mechanism, but here it is partially reversible. It is not like that. So airflow limitation is in both cases. So this is the distinction between the COPD and asthma. You are supposed to know it. And then we have difference between COPD and bronchial asthma, like prevalence is 5 to 10% asthma and more than 10% is COPD. Inflammation is eosinophils are there, neutrophils are there. And this causal T helper cells is because of the hyposensibilization. Here is the stop smoking. We have to. And smoking we have, there is no smoke in asthma, but yes, it is in COPD. Symptomatic T helpers are bronchodilators, and there are both are bronchodilators we can manage. Progress is stabilization, healing. There is a stabilization, there is a healing process, but there is a progression. We can stop the progression. And disease of onset is rapid, there is a progressive. Reversibility of the obstruction is over 15%. No or small. We don't have any reversibility. Hyperactivity is always, but there is sometimes. So you have to know about these 8 or 9 differences between the asthma and COPD. Then you can treat a patient very nicely. Now, classification of bronchial asthma, we have 4 stages. We have mild intermittent asthma, mild persistent asthma, moderate persistent asthma, severe persistent asthma. So these are the 4 levels of the bronchial asthma is there. And then we have the clinical classification of bronchial asthma. We have severity, intermittent, mild persistent, moderate persistent, and severe persistent. So according to this, there is the, I would say, more than 12 years of old, we have to have symptom frequency. As you know, intermittent is equal to 2 weeks per week, and it is also mild more than 2 weeks, and moderate persistent daily and continuous process in the severe case. But in the nighttime symptoms, it increases. With the passage of time, and in the, I would say, then it is the marker. FE1 is the marker. Suppose if it is more than 80%, it is intermittent. It is more than, it is when mild percent. So there is no difference between intermittent and mild so far as FE1. FE1 is the first forced expiratory volume in first second. As you know, we'll come to know the lung function. Lung function is the marker, which this one of the parameters of the lung function is FEV1. So then we have moderate percentage 60 to 80% and severe percentage is less than 60%. FE1 variability is less than 20% is the intermittent, 20 to 30% is the mild persistent, more than 30% is the moderate persistent, and more than 30% is severe persistent. Then we have 2 days or equal to per week, it is SABA, we get the SABA, small acting bronchial, agonists, and short acting bronchial asthmatics, that's a SABA. And it is 2 days per week, and we have more than 2 days per week, it is the mild persistent. Daily we have moderate persistent, twice per day we have severe persistent. So it depends upon the FE1. This is one of the markers which shows the variability, and the SABA is because of that we have to have the SABA use, means short acting bronchial agonists, this beta agonists. They're like terbutaline or salmeterol. Now, also spirometric classification of COPD severity based on post-bronchodilator is FE1. Mild, it is FE1 by FVC, it is a ratio if it is less than 0.70. FE1 is 80% predicted. Stage 2 moderate, we can FE1 by FVC is less than 0.7. I would say 50% is less than or equal to FE1% is less than 80% predicted. But these two stages, stage 3 is severe and stage 4 is very severe. It gives less than 50% and it is less than 20%, 30% is the FE1 FVC and it is less than 50% FE1. So this is also one of the criteria of classifying the COPD, classification of COPD based upon post-bronchodilator FE1. So both asthma as well as we can see FE1. FE1 is the forced expiratory volume in first second. You will learn you have already learned this in the physiology, but you can I can demonstrate the class for this FE1 if you are sensitive, if you are really interested to do so. So therapy of bronchial asthma is diagnosis. We have to have a regular examination and monitoring this dip stage and control of the worsening factors. We have to control it. Long-term pharmacological treatment is there. Management of the asthma exacerbations. What are the, I mean, if there is a precipitation, there is the exacerbation of the, we have to manage it. Education and leading of the asthmatic patients to partnership in treatment. So we have to educate them, because education is very important. They have not to be without the drugs and they have to take precautionary actions, and that is very important. This is the role of the doctor, that to educate the patient. Therapy of acute symptoms in AB. So relieving is rescuing drugs. Relieving is rescuing drugs. We don't. Relievers means are those which are, I would say, rescue population. Short-acting beta-2 sympathomimetics, beta-2 agonists, this is SABA. Muscarinic antagonists, we have anticholinergics, antimuscarinics, that's called a SAMA. These are the muscarinic, short-acting muscarinic agents. And systemic corticosteroids in rescue dose. We have to give that rescue dose so that it cannot go in the systemic compartment, so that there is a lot of side effects of the systemic corticosteroids. You have to take the care. Then theophylline. This is the therapy for, I would say, acute cases of this pulmonary disease. Long-term pharmacological treatments, we have controllers, preventive drugs, inhalative and systemic corticosteroids. So you have to give the inhalation and systemic corticosteroids. This is the controller. Chromones, chromoglycates, these are the chromones, long-acting beta-2 sympathomimetics. We have beta-2 against LABA. These are long-acting because this is a long-term treatment. That's why we give the long-acting. Theophylline with sustained release. There is a theophylline which has a sustained release we can give for the long-term. And anti-leukotrienes, we have leukotriene modifiers. And then we have omalizumab. These are antibodies against IgE. This is for the severe cases. And then we have, low, medium and high dose inhalational corticosteroids, adults and adolescents greater than 12 years of age. Like we have different, I would say, diluents, CFC, chlorofluorocarbons, and then we have HFA. HFA is also, I would say, the newer ones. This is very important for the newer ones, these diluents, HFA. And then you see, you have total daily dose, low, medium, and high. So we have demarcated the doses. Beclomethasone, CFC, having it is 200 to 500 milligram, 200 to 500 microgram low dose. Medium is more than 500 to 1000, then less, greater than 1000 microgram is high. Beclomethasone dipropionate in HFA diluent 100 to 200 is the, I would say, microgram, and we have more than 200 to 400 microgram or more than 400 microgram is in HFA. Then budesonide, it is a DPI, it is 200 to 400, more than 400 to 800 and more than 800. Then Cislisonide, HFA, is the vehicle. 80 to 160 is the microgram, and then we have 160 to 320 and more than 320. Dexamethasone propionate. It is also in DPI or FPI. It is an inhalation, and 100 to 50 is the low, more than 250 to 500, and more than 500 is the high. Then mometasone furoate is 110 to 120 to is the low, to, greater than 20 to 220 to 450, 440 is medium, and more than 440 is high. And triamcinolone acetonoide is 400 to 1000 is low, 1000 to 2000 is medium, and 2000 is more than that it is high. So this is not a table of equivalence but of estimated clinical compatibility. Most of the clinical benefits from ICS is seen at low doses. We should give the low doses of these corticosteroids. High dose are arbitrary, but most ICS are those that with prolonged use. So we have to give the prolonged high dose associated with the increased risk of the systemic side effect, because we have to take the risk. There is a risk-benefit ratio. So this high dose is because we have to take the risks. Now this is also the low, medium and high dose inhaled corticosteroids 6 to 11 years. This is lesser than the but the drugs are of the same. So you have to make this clear indication that from 6 to 11 years is one sort of doses, and from more than 12 years is the other sort of doses. So you have to make the comparison between the children and the adults. From 12 onwards, the adults, so far as the asthma or this COPD is concerned. Now, management of the COPD. First of all, we have to have the diagnostics and disease monitoring. That is very important. Diagnosis is very important. Reduction of the risk factors. Treatment of the stable COPD. Treatment of the exacerbation. These are the four, points which are in the management system. Now, managing stable COPD, all COPD patients. Avoidance of the risk factors. We have to avoid risk factors like smoking cessation. We have to tell the patient that you have to leave the smoking. And then a reduction of the indoor pollution. We have to make the pollution-free atmosphere for the patient. Reduction of the occupational exposure. And there are pollens which are going here and there in the atmosphere. You have to. Then influenza vaccination is very important. Now this is the patient recommended dose. This is the global strategy for diagnosis, management of prevention of COPD, management stable COPD, pharmacological therapy. Now we have patient, A, B, C, D. Recommended first choice, we have to give the SAMA or SABA. Alternate is LAMA or LABA, or SABA and SAMA. And other possible treatments are therapy, theophylline. Same is the case with LAMA or LABA in the B category, and LAMA and LABA plus. It is or and or in the first thing. LAMA and LABA is the alternative, and then SABA and or SAMA theophylline. So theophylline is there also. These are the other possible treatments. Then we have C, ICS like corticosteroids plus LABA or LAMA. So we can say LAMA and LABA, or LAMA and PDE4 means theophylline, or LABA and PDE4 like theophylline, and SABA and or SAMA and theophylline. See, here there are options. Then we have ICS like corticosteroids plus LABA and or LAMA. Now in the alternate we have ICS plus LABA and LAMA, or ICS plus LABA and PDE4 theophylline, or LAMA and LABA, or LAMA and PDE4. And then we have carbocysteines. Carbocysteine is a dilator bronchus. This carbocysteine, is also antidote for the paracetamol. And SABA and SAMA theophylline. See, this is the recommended first choice, then the alternate choice, so you have to remember these things and how you have to manage with these drugs. Now, treatment of the stable. Now we have a stable, COPD. Pharmacological, we have bronchodilators, glucocorticosteroids, other forms. And non-pharmacological, we have smoking cessation, rehabilitation, oxygen therapy, mechanical assistance of the ventilation, and surgical treatment. This is the last option. Now, bronchodilators, we have parasympatholytics, beta-2 sympathomimetics, methylxanthine, and combination. So parasympathomimetics means like it is atropine type, but it's not atropine here. There is ipratropium, then short acting. Beta 2 symptom is salbutamol and this salmeterol. Methylxanthine is, say phosphodiesterase inhibitors, PDE4, like we can say, and methylxanthines we can also call them, and it is theophylline also. Then we have combinations therapy, so bronchodilators. So other forms of pharmacotherapy, vaccination, influenza, pneumococcus. Substitute therapy is alpha-1 antitrypsin. Antimicrobial is exacerbation when there is a precipitation or there is a, infection. Mucolytics, antioxidants, immunoregulators, and antitussives that I have already told. Because antitussives sometimes you have to give in the COPD or in the, bronchial asthma. So drugs used in the therapy of the bronchial asthma is COPD. Now, role of beta 2 agonist in the therapy of the obstructive airways disease, the base of the symptomatic treatment, bronchial asthma. Drug of choice in acute exacerbation of asthma is reliever. It should be relieved. Preventive drug in asthma induced by effort. In monotherapy indicated only in intermittent asthma, that is dyspnea attack, less than 1 per week. So there is an attack, there is oxygen, we cannot cope with the oxygen. Night dyspnea, sometimes in the night also, less than 2 times per month. So PEF, we have to have the PEF, forced expiratory flow, and or first forced expiratory volume in first second better than 80%, or their variability is under 20%. So 80% should be there. If it is less than 80%, there is, we have to see the bronchial asthma. All other levels of the asthma, basic symptomatic drug is rescue treatment. So we have to have a rescue treatment. Then so there are 2 treatments, reliever and rescue treatments. COPD, basic symptom drug if the disorder is minimum partially reversible. If it is partially reversible, it is COPD. Other in patients with the airways disease with presence of the obstruction, as basic symptomatic drug is bronchiectasis or obliterating bronchial lithosis, etc. So we have to see the options between the COPD and others. Now, beta 2 agonists I have already told, beta SABA, LABA, and LABA inhibitory. So we have 3 options. LABA, SABA means short-acting, beta agonist. Salbutamol is there, phenterol is there, terbutaline is there, albuterol is there, levolbuterol. These are the SABAs. And LABA is peroral. It is salbutamol, clenbuterol, procaterol, caterol. These are the 3, SABA, LABA, long-acting, beta agonists. Now we have LABA inhalatory, because they are also in the inhalation, like we can give the pumps. Salmeterol is there, formoterol is there, indacaterol is there, vilanterol is there, olodanterol is there. So there is the SABA, there is the LABA peroral, and there is the LABA, inhalatory. Then we have parasymptomalytics like ipratropium bromide, oxytropium bromide, tiotropium bromide, aclidinium bromide, glycopyrronium bromide, and parasymptolytics in combination. We have now, combination, like we have parasymptolytics like which are, short-acting ipratropium bromide plus phenterol, ipratropium bromide plus salbutamol, glycopyrronium plus indacaterol. So this is the combination. It has both parasymptolytics plus, and it has also beta 2 agonists. Now tiotropium bromide, slower onset than this ipratropium. They have got the slower onset, and they have got the longer time of persistence at M receptors. They remain there for a longer time. So M1, 14 to 16 hours. M2, 3 to 6 hours we can give. M3, 34 to 7 hours. Ipratropium is 60 minutes. So ipratropium is 60 minutes. So you see what is the difference, tiotropium and ipratropium difference. So pharmacodynamic type of selectivity is this. So tiotropium is slower onset than ipratropium. Ipratropium is So tiotropium is, I mean, say longer time of persistence at M receptors. So for ipratropium is only 60 minutes. So we can say mechanism of action of the mechanism of action of HDAC. HDAC is nothing but HDAC is actually the histone acetyl transferase or histone deacetylase methylxanthine. So the difference between this corticosteroids and theobromine is this theobromine HDAC is plus. But so far as corticosteroids are concerned, they go intracellularly and they co-activate the receptors. So HAT, what is HAT? HAT, you know, HAT is the histone acetyl transferase. So theobromine is deacetylator and corticosteroids are co-activator. So with the result, this gene, inflammatory gene is being responsible that we give the corticosteroids. It goes intracellularly, and there are two types of acetylators and deacetylators. This is, I mean, say, taken into consideration. And this is the mechanism between the corticosteroids and theophylline. And then inflammatory stimuli, you know, this is interleukin 18, TNF alpha, which is shown over here, and then NF kappa B, it is P65 and P50. It is also inflammatory protein. GM-CSF is also inflammatory protein. So this, I would say, these two drugs, once we give the theophylline corticosteroids, they are acting at the, I would say, nuclear and they control it, the activator and the acetylation and deacetylation. They activate it. They take the balance of this. And the corticosteroids act for a longer period of time. That is why it should be given, I mean, say, for a longer period, and it maintains it is. Once you withdraw the corticosteroids, there is more precipitation. So it has been told, it has been said that beta 2 agonists and these, I would say, they are, I would say, synergistic response. Once you give the theophylline and corticosteroids or LABA or LAMA or this, they also act synergistically. Now, this is the chromatin remodeling and the gene expression. So, representing gene silencing is the transcription factor, and then we have a co-activator and co-pressor, histone acetyl transferase and co-repressor. This histone deacetylase, that's previous slide, and then inflammatory protein is being inhibited through the mRNA, through the mRNA. So this is going through the genetic setup. This goes in this, I would say, this makes the responsibility of the genetic of the gene which is responsible for the inflammatory proteins. Now, reasons for decreased activity of the HDAC in COPD. Why it is like that? Why there is a reasons for decreased activity of the HDAC, histone deacetylate. So, you know, cigarette smoking, inflammation, then nitrous oxide, then antioxidants we have, then peroxynitrile. So this is a nitrous, then there is a increase of the HDAC. So this, these, I would say, smoking and all that in COPD, and then we give the theophylline, and it increases the, I would say, it takes the, I would say, inflammatory genes are being checked by this HDAC, histone acetyl transferase. So then this proteasomal destruction is being carried out by this, I would say, this HDAC in COPD. So cigarette smoking is the main cause, pathophysiology of the COPD, that you have to remember. And then xanthine, nowadays we give preference of SR forms, like we give the slow sustained release, because they have got a lot of side effects of the, I would say, xanthine oxidase inhibitors, like particularly the methylxanthine, or we can show theophylline. Use as bronchodilators after beta 2 agonists. First of all, we have to give the beta 2, like SABA and LABA. Then we have to give the bronchodilators and anticholinergics. So first of all, we have to give the beta 2 agonists and anticholinergics, then use as bronchodilators after. So used particularly in COPD, less in asthma. But you have to use in COPD but not in asthma. Monitoring of the activity by determination of the serum or saliva content of theophylline and its relation to effect. I have told you so many times that this monitoring process of the theophylline therapeutic drug monitoring is very important. It is therapeutic range is 10 to 20 micron. So once you have less than 10, it is under therapeutic, means it is below the therapy, and 10 to 20 is therapeutic, and more than 20 micron per ml is, I will say, toxic. So it is very indicator for the drug-drug interaction, or we can rationalize the treatment of theophylline by seeing the concentration of the drug in the body. So this is called the therapeutic drug. New class of the PDE and their inhibitors, we have new class of the drugs also. Indication of xanthine in COPD. Per oral SR forms, moderate and severe obstruction if this, especially third and fourth stage, we give this. And prevention of the night obstruction and oxygen desaturation, we give this. Disease of small bronchioles, once it goes inside and it is the bronchioles which are responsible, we have to give. No response to previous anticholinergics and the bronchodilators. If there is no response, then only we have to give the xanthines. Now, in COPD, per oral form with short effect only in cases with better individual toleration. They can tolerate because they have got a lot of side effects. You know, the theophylline goes beyond, there's a palpitation, there are so many gastric irritation. And intravenous form, we have to give acute exacerbation. There's acute, I mean, say, exacerbation of the COPD, then only we have to give with the decompensation coronal pulmonale at that time, where it did not help usual therapy, essential monitoring. So at that time we have to give the intravenous and slow intravenous. We have not to give the fast intravenous. Now it is an obsolete, it is not given. Methylxanthine, we have theophylline 12 hourly, and we have, I mean, say, theophylline 24 hourly we have to give. Aminophylline is a short acting, and aminophylline is 12 hourly also given. And etophylline is also another form, is a short. Etophylline, theophylline is mixed, and doxophylline is the, I mean, say, another form. So there are different formulations of the theophylline, and which depending upon the, I mean, say, for how long you want to maintain in the patient. Then we have a selective PDE4s. So increase, what is the mechanism behind? Increase CMP, activation of the T cells, WBC's functions, and then we have activation of the macrophages, relax ASM, dual inhibition of the PDE3, PDE4. There are two types of substances. Then cytokine release, then TNF alpha. So rolipram, citalopram, first generation, and we give nausea, vomiting. So we have to see adverse effects, drug-drug interaction, where we have to maintain the dose. Silomilast, roflumilast, piclomilast, second generation. Anti-inflammatory and immunomodulatory effects, less bronchodilation, less adverse effects. So we have to see what are the drugs, first generations, and if there is a nausea and vomiting, how we can control when there is a, I would say, more side effects of the drugs. Now, PDE inhibitors and inflammation, you know, T lymphocytes, production eosinophils, this is the inflammation, fibroblast, then we have airway smooth muscle, enhanced smooth relaxation, mucus gland, decreased mucus. So these are the other, I mean, phosphodiesterase inhibitors responses. So macrophages are being decreased, TNF alpha, LTC4, LTB4 release, increasing interleukin 10, mast cells are decreased, neutrophils are decreased, endothelial cells are decreased, adhesion molecules are decreased. So this is the phosphodiesterase inhibitors. They have got a lot of, I would say, inhibitory response on the inflammation. Now PDE4 inhibitions and inflammation, we have inflammatory mast cells, eosinophils, T cells, macrophages, neutrophils. So structural remodeling, airways, smooth muscle, I would say mucus, and then epithelial cells. PD inhibitors, for example, columilast and roflumilast. So these are the newer drugs which are the PDE4 inhibitors, which are specific, and these are the, I would say, coming drugs but PDE4 only theophylline is we were giving, and now its use is abated because of the side effects and adverse drug reaction is being shortened. It is not now being. So newly recently approved PDE for roflumilast, and it was in July 2010, 2010, and approved by EMA for use in Europe. Once daily, we can indications maintenance treatment of the severe COPD, FE1, post bronchodilator, and adverse effects is diarrhea, weight loss, nausea. So these are all the newer PDE4s, like we have mentioned in the in this slide. Now, corticosteroids. What is the role of the corticosteroid? Not as a direct muscle relaxant. It is not, however, indirect bronchodilator. So you should remember, it is not the direct bronchodilator. Strong suppression of the inflammatory response, that is by inhibition of the arachidonic acid release from cell membrane, decrease the production of the PGs and LTs, inflammation mediators, stopping and migration of the decrease of the bronchial hyperactivity, edema, suppression, prevention of the chronic irreversible change, hypertrophy and hyperplasia of the airways, smooth muscle, subendothelial fibrosis, and thickening of the mucous basal membrane. Increased sensitivity in the expression of the beta-adrenergic receptors of smooth muscles to beta-2 agonists. So corticosteroids are very important. I would say resistance is near there. I have told you the beta-2 agonists, once we use the agonists, there is a down regulation. So it can maintain the, structure of the bronchus by the corticosteroids. Inhalation corticosteroids is also there. That's called the ICS. Local effect is there. Corticosteroids are soluble in fat, beclomethasone, budesonide, fluticasone, longest deposition time in lungs. So they remain there for a long time. Best therapeutic corticosteroid receptor is there. In dose up to 800 micrometer to 1 milligram per day, you can give low incidence of the systemic adverse. So it does not go in the systemic compartment. As you know, this is the bad drug. Once it is in the systemic compartment, once it's in the blood, it has got a lot of devastation of adverse drug reactions. So decrease of doses after stabilizing the clinical status. Adverse effects are oropharyngeal candidiasis, dysphonia, cough prevention, washing out of mouth, use of spacers. So adverse effects of many even in the oropharyngeal cavity. Now, advantage of the inhalation administration is direct drug effect, low total dose, minimalization of the adverse effect because of that. So inhalers, we have MDI, metered dose inhalation, MDI plus spacer, DPMDI, dry powder metered dose inhalation, DPI nebulizer, and we can discuss this. So these are the, 4 types of the MDI metered dose, MDI plus spacer, DPMDI means dry powder, metered dose inhalation, DPI, and nebulizer, and then there is a discussion. So these are the different, these inhalers. And then systemic corticosteroids we can give sometimes, and there is in the fourth stage of patient is in the fourth stage. Short-term booster cycle, 3 to 10 days. Is the short-term maximal therapy for treating of severe persistent asthma treatment failure, usually as an introduction of the long-term therapy of the patients with unstable asthma, or in case of the sudden worsening of the clinical state. Long-term per oral corticosteroid therapy is daily or alternate, that is in 1 dose every other day. In patients with the severe persistent asthma, per oral administration preferred to parenteral. During attack should be administered within 45 minutes. So hydrocortisone, prednisolone, methylprednisolone, triamcinolone. So these are the different drugs which are given systemic corticosteroids at the fourth stage. So corticosteroid in COPD, it is inhaled in COPD only in symptomatic patients with positive response, or in patients with FE1 is less than 50%. Third and fourth stage we can give inhalation. In exacerbation with ATB, we have to give no influence on FE1. So ATB1, we have ATB where it exacerbates, then we have give the, it does not influence the FE1. Long-term per oral treatment is not recommended. We have not recommended. Now, inhalatory corticosteroids, we have beclomethasone, budesonide, fluticasone, and mometasone, and cyclisonide. Combined with beta-2 we can give. I have already told you. We can combine these corticosteroids with the beta 2 agonists. Now, new bronchodilators. We have ultra-LABA. These are the newer coming. Then we have tiotropium, VIP analogs, potassium openers, agonists of bitter taste receptors, and triple inhalers. Like we have LABA, LAMA, ICS. It is a severe asthma. It is a triple inhaler. Long-acting beta agonists, and then we have muscarinic agonists, and then we have, corticosteroids. So this is the new bronchodilator pattern. Ultra-LABA, tiotropium, VIP analogs, potassium openers, agonists of the bitter taste receptors, and triple inhalers. Now, recently developed combination inhalers for COPD, we have LABA and ICS. Like LABA, flutoside propionate, salmeterol, budesonide, formoterol, several years of experience we can give. Then mometasone and formoterol, comparable effectiveness, more rapid onset. Beclomethasone, formoterol, aerosol. Vilanterol, triflutate, flutosonide, furet. These are the ultra-LABA, 24 hours, highly selective for beta 2. And then we have flutosone, furet. It is the vilanterol, triphenylate. And then we have indacaterol, mometasone, and ciclisonide and formoterol. These are the novel inhalers recently inducted. Now they have LABA and LAMA, formoterol, tiotropium, indacaterol, and glycopyrenium. And then we have olodaterol and tiotropium, cameterol and tiotropium. So these are the recently developed LABA, LAMA. What is the combination? And because of that. Then MABA, single molecule with both. Then this is a recently developed combination inhaler of the COPD, MABA and triple therapy. MABA is single molecule. It is a single molecule with both antimuscarinic and beta 2 agonist modes of action. These are the symbolic names. These are not yet come in the market. And triple therapy, LABA, LAMA, ICS. Single inhaler, better compliance. Salmeterol, flutosone, propionate, and tiotropium. So this is the triple therapy where all the drugs like LABA, LAMA, and ICS. Then this is the, this jungle of drugs which have been given. And as you know, the bronchial asthma or the COPD, it is having the network of the pathophysiology. So that's why we cannot have a specific drug for it. That is the bottom line. Then we have anti-leukotrienes, antagonists of leukotriene receptors, like we have zafirlocast and accolate, and montelukast, singular ectomone, montelukast, montelukast, spiromone, and astaponone. So one daily and for 6 years. And that is zafirlocast we give 2 daily and for 12 years. And then we have lipoxygenase inhibitors, xylitol. It is not given, but it is also the anti-leukotrienes. Then new corticosteroids, reducing oral viability, absorption from lungs, inactivation in circulation. Dissociated steroids to support trans repression and non-genomic effects and to reduce trans activation. Non-steroidal selective glucocorticosteroids activators, like we call it the SEGRA, selective glucocorticosteroid receptor activators. Activation of the HDAC2. HDAC2 means histone deacetylase 2. New corticosteroids. Now new anti-inflammatory also is there. ICS, like we have got ICS, this is the golden standard. Problems in case of the concomitant rhinitis or resistant to CS. ICS are not so effective against the neutrophil inflammation. Now, new anti-inflammatory drugs, we have PD inhibitors, roflumilast, kinase inhibitors. There are so many adhesion molecule blockades, PPARY agonists. These are the 4 types of the new anti-inflammatory, because inflammation also produces the bronchoconstriction. Now, anti-allergy treatment, we have anti-IgE therapy, omalizumab, lumlizumab, and anti-CD23 and antibody. Mast cell inhibitors, we have chromones and docoronil, indirect stabilizers like furosemide. And these are the newer, anti-allergy treatments, because IgE, anti-IgE and mast cell inhibitors. Omalizumab, anti-allergic in allergic asthmatics, recombinant human monoclonal antibody IgG against human IgE. Inhibitors bound to IgE to receptor on mast cell and basophil. It is more than 12 hours. Expensive. It is $10,000 per year. It is very costly. So, chromoglycates, anti-inflammatory effects we have for continual anti-inflammatory treatment of milder bronchial asthma forms induced by cold air, allergens, physical and mental activity and air pollution. Chromoglycates for preventive use and not to acute relief from symptoms. So ameliorate lung functions, decrease frequency and severity of the attacks, decrease airways hyperactivity. Advantage: safety tested during 50 years of use. Content of physicians is the content. It gives the content to the physicians and application in children. So chromoglycates have some say in bronchial asthma. Now chromoglycates were decided weaker anti-inflammatory. They are weaker anti-inflammatory. No prevention of the remodeling. Full action after 4 to 6 weeks. It takes time. Dosage is 4 per daily. No decrease of mortality, and we have irritation is the only side effect. Chromoglycate formulation, we have natrium chromoglycate, or we can give nalchrome, and then we have natrium nidocoramil. It is as a dilate mint. So asthma therapy, future challenges. Inhibitors, key effector cells. Mast cell inhibitors, we have eosinophil inhibitors. This is the, this is the newer, concept that asthma therapy future challenge will be the mast cell inhibitors and eosinophil inhibitors. And then we have interleukin T helper cytokine therapy, interleukin 4 antagonists, interleukin 13 antagonists, interleukin 5 inhibitors, sulfate, tosylate, OX4 antagonists, block of lipid mediators. So these are the asthma future challenges. And immunotherapy, we have treatment targeting immune deviation, specific immunotherapy, injection of the specific allergen, sublingual immunotherapy with house dust mite, with peptides from T cell epitopes from cat allergen, and vaccination of the mycobacterium vaccine shifted from T helper cells to 2 to T helper cells 1. Targeting, nowadays we have a target therapy, targeting TRUGs and targeting dendritic cells. This is the immunotherapy. Thank you very much. This was all about the, this class. I hope if any question, if any, addition or alteration, you can ask for that. Thank you. But you have to go through all this, and you have to know the recent advance, why it is a severe disease. It is a very immunomodulatory effect is there, and there is so many chemotactic substances, inflammatory substances. So that's why this disease is a very dirty disease, I should say, because it's not handled. It is a lifelong disease. Thank you very much.